Hello, good morning everyone. Now, with the continuation of the cirrhosis, causes of the cirrhosis, we will discuss today about the biliary cirrhosis, one of the etiology of the cirrhosis. That the biliary cirrhosis is the cirrhosis caused by the injury to the bile duct. In this way, there are the three types of the biliary cirrhosis: primary biliary cirrhosis, secondary biliary cirrhosis, and sclerotic cholangitis. Primary biliary cirrhosis. So primary biliary cirrhosis is a cirrhosis of the chronic, progressive and often fatal cholestatic liver disease characterized by the destruction in the intrahepatic bile duct. There is a destruction of intrahepatic bile ducts, portal inflammation. When there is a destruction, there will be the inflammations surrounding the bile duct, and that causes the scarring surrounding them and leads to the cirrhosis, and this cirrhosis causes the liver failure, and it is a non-suppurative granulometer destruction of the medium-sized intrahepatic bile duct. Non-suppurative granulomatous destructions. So there is a formation of granuloma and not a suppurative inflammation. It is a non-suppurative inflammation. Mainly it is caused by certain immunological mechanism. Most commonly occurs in a middle-aged about 20 to 80 years, and females are most prone for that. So it is a autoimmune disease. Possibly a autoimmune cause is there. Why? Because it is associated with other autoimmune disorders, and there is a destruction of intrahepatic bile duct mediated by the T cells. जो granulomatous reaction होता है, there is a T cell activation. So here also there is a T cell mediated destruction is there, which reacts with aberrant mitochondrial protein on the bile duct epithelial surface. Bile duct के epithelial surface पे mitochondrial protein होता है. There is a reactions with this mitochondrial protein is by the T cells is the process of autoimmune disorder associated with the biliary cirrhosis. So here is the pathogenesis of the primary biliary cirrhosis. There is a immunological bile duct injury occurs there. This injury is because of immunological mechanism. ठीक है, जो mitochondrial protein है उसके against immunity. ठीक है, so immunological mechanism is there causing the bile duct injury. Because of this, there is a aggravation of the bile duct injury by the hydrophobic bile salts. This injury is aggravated by this bile salts, and there is a when there is a injury, there is a cholestasis and retention of the hydrophobic bile salt in the liver. तो liver में गया, क्या करेगा? Liver cell damage, apoptosis, necrosis and fibrosis leads to the cirrhosis, and this will lead to the liver failure. Morphologically, when we see macroscopically, grossly, liver appears green in color. Why? Because of the bile duct injury. So bile duct injury is there, so there is a stasis of the bile in the liver, leads to the color of the liver appears as a green. Weight is slightly reduced later on, and overlying surface, when we see the capsule initially is smooth and glistening, but later on there is a granularity appearance. Because of the fibrosis, there is a micronodular cirrhosis will be formed. So uniform micronodularity will be there, and by the end of this picture, there is a this is indistinguishable from the secondary biliary cirrhosis or cirrhosis from the chronic hepatitis from other causes. But initially it is green in appearance and micronodularity. So these two are the features related to the biliary cirrhosis. This is the cut surface of the liver. You can very well appreciate that there is a green appearance of this liver, and there is a slightly microgranularity might be there, but in the next one you can appreciate this green, and it is not smooth. तो जैसा आपको एल्कोहलिक में दिखा था, बड़े बड़े नोड्यूल दिख रहे थे, माइक्रो एंड मैक्रो नोड्यूल. हियर because these nodules are very small, so there is a fine granularity you can see in this biliary cirrhosis. And microscopically, during the pre-cirrhotic stage, you will see there is a dense lymphocytic infiltrations in the portal tract along with the macrophages and plasma cells. And terminal and conducting bile ducts mein there is a infiltrated by the lymphocyte, and there might be non-caseating granulomatous inflammation. With the time, there is a progressive secondary hepatic damage occurs, and the portal tract show the bile ductal proliferations, inflammations, and necrosis of the adjacent periportal hepatic parenchyma. Over years or the decade, portal tract scarring, bridging fibrosis will be there, leads to the cirrhosis. Certain stages are there that in the initial stage, stage 1, that is named as portal stage, there is a normal size triad is there with the portal inflammation, lymphocytic infiltrate will be there, and there is bile duct damage and granuloma might be seen there. Then the second stage, there is a periportal stage, jabki periportal area will be involved. So there is a triad will be enlarged in this way, and there is periportal fibrosis or inflammations, typically characterized by the finding of proliferation of the small bile ducts. In the third stage, septal stage, there is active or passive fibrous septa. Then there will be the nodularity appeared there is the in stage 4 biliary cirrhosis. Because these are small micronodular cirrhosis, it appears as a garland. So in this way, you can see this is the portal triad or portal area. There is a dense inflammatory, chronic inflammatory cell infiltrate, macrophages, inflammation, eosinophils in a periportal area. Here you can see this is the inflammation around the portal triad, lymphocytic infiltrate, and ductal proliferations is also there. Same way here also the portal triad inflammations, chronic inflammatory cell infiltrate around the portal triad. And here is this is the fibrous bridging between the one portal and the another portal area. And here is the granuloma formation is there. This is the poorly formed granuloma. It is a non-suppurative type of the granuloma is there with the florid duct lesion is there. Clinically, it appears as insidious in onset, mostly female predominant. At 20 to 80 years is more common, mean about 40 to 50 years. So how it presents? It will present it with the pruritus. Skin mein there is a depositions of this bile pigments are in a underlying skin, appears as pruritus, jaundice, hepatomegaly, and there is a derangement in the cholesterol metabolism, leads to the xanthoma and xanthelasma. There is a deposition of the fatty acid underneath the skin, so yellowish depositions in the skin, and there is a symptoms of hepatic decompensations to maintain these cirrhosis, or the before the cirrhosis will be there. Portal hypertension or variceal bleeding will be there with the hepatic encephalopathy. So what will be the cause of death? Liver failure because of the portal hypertension. There is variceal hemorrhage and complications will be there along with the liver failure and intercurrent infections. What investigation would you like to do? There is a hepatic or bile duct injury is there and obstruction is there. When there is a ductal or cholestasis is there. Then the alkaline phosphatase, elevation of the alkaline phosphatase and gamma glutamyl transferase, gamma GT. So alkaline phosphatase and gamma GT are the markers for the cholestasis. In this way, there is an increased serum alkaline phosphatase, increased serum cholesterol, hyperbilirubinemia. Which one? कॉन्जुगेटेड, बाइल डक्ट का ऑब्स्ट्रक्शन है तो कॉन्जुगेशन, अगर लिवर सेल फेलियर होगा तो कॉन्जुगेशन नहीं होगा, अनकॉन्जुगेटेड रहेगा, बट हियर इज द बाइल डक्ट का ऑब्स्ट्रक्शन, सो इट विल लीड टू द कॉन्जुगेटेड हाइपरबिलिरुबिनीमिया. इंक्रीज सीरम बाइल एसिड्स. along with this, one of the important is anti-mitochondrial antibody for the primary biliary cirrhosis. It is specific for primary biliary cirrhosis. It is highly characteristic of this primary biliary cirrhosis, 90 to 95% of the test. And this is the antibody against the E2 subunit of the pyruvate dehydrogenase complex in the dihydrolipomyed acetyl transferase located on the inner surface of the mitochondrial membrane. And there is, along with this, increase in serum immunoglobulin M. As it is an autoimmune disease, so along with this, other autoimmune are also associated with this. What was that? The extrahepatic manifestation of autoimmunity is Sjogren's syndrome, scleroderma, thyroiditis, rheumatoid arthritis, Raynaud's phenomena, membranous glomerulonephritis, celiac disease. These may be associated with this primary biliary cirrhosis. Now the secondary biliary cirrhosis, all you know, जहाँ पे भी प्राइमरी होता है मतलब cause itself in the that lesion, and secondary because of other causes. So that is result from often from the uncorrected obstruction of the extrahepatic biliary tree. तो obstruction हो रहा है, क्यों हो रहा है obstruction? There are many reasons for the obstruction. Adult में अलग है, children में अलग है. Cause of the obstruction in the adults, there is extrahepatic cholelithiasis, malignancy in the biliary tree, carcinoma of the head of the pancreas, stricture from the previous surgical procedure. These all will lead to the obstructions. And in the children, how it occur? Maybe because of the biliary atresia, cystic fibrosis, choledochal cyst, or there is bile duct syndromes, paucity of the bile duct syndrome. So what will be the pathogenesis? Because there is a stasis by the any cause of that obstructions, it will causes the obstruction of the bile duct, causes the bile stasis in the bile canaliculi. Stasis हुआ, then because of this stasis, other bile duct to manage this will be proliferated. So bile ductular proliferations will be there, and because of this, there is a periportal inflammation, edema and neutrophilic infiltrations will be there. Because of this neutrophilic infiltration से क्या होगा? There is a leukotrienes will be released and leads to the fibrosis, scarring and cirrhosis. And when there is a subtotal obstruction, there will be the secondary bacterial infection of the biliary tree, leads to ascending cholangitis. So ascending cholangitis is a feature of secondary biliary cirrhosis, and this aggravates the inflammatory injury. How it appears? Liver grossly green pigmentation is there. On the cut surface, there is a hard, finely granular appearance. And in the microscopic view, you will see there is a coarse fibrous septa. जहाँ पे भी इंजरी हुई है वहीं पे ही रहेगा ये, फिर जहाँ जहाँ इंजरी होगी वहाँ पे. So there will be fibrous septa divides the liver in a jigsaw like pattern. पूरे यूनिफॉर्मली डिस्ट्रीब्यूटेड नहीं रहेगा, इट विल बी अपीयर्स एज जिगसॉ लाइक पैटर्न. स्मॉल एंड द लार्ज बाइल डक्ट्स कंटेन द inspissated pigmented material, that is the bile. There is extensive proliferation of the bile ductules and the edema, extensive feathery degenerations and formation of bile lakes will be there. Then neutrophilic infiltration of the bile ducts. Here you will see neutrophilic infiltrate, primary में lymphocytic infiltrate is there. Here jigsaw like pattern is there. There the fo uniformly distributed microgranularity. ठीक है, and there is extensive proliferation of the bile ducts and edema. Clinical features are same as in the primary biliary cirrhosis, and investigations are also same except that the anti-mitochondrial antibodies that were present in a primary biliary cirrhosis. Now, primary sclerosing cholangitis. It is characterized by the, as you know, स्क्लेरोजिंग एंड कोलेंजाइटिस. स्क्लेरोजिंग मतलब स्क्लेरोसिस हो गया है, कोलेंजाइटिस बाइल डक्ट का, आइटिस इन्फ्लामेशन. सो देयर इज ए इन्फ्लामेशन ऑफ द बाइल डक्ट विद द स्क्लेरोसिस सराउंडिंग द बाइल डक्ट. ठीक है, सो इट इज कैरेक्टराइज्ड बाय द इन्फ्लामेशन of obliterative fibrosis of the intrahepatic and extrahepatic bile ducts, and there is with जो preserve दूसरे जो bile ducts होंगे, there will be dilatations of the preserved segments of the bile ducts. So inflammation is there. It is associated with the inflammatory bowel disease. Inflammatory bowel disease में क्या क्या आता है? Ulcerative colitis and Crohn's disease. So it is particularly associated with the ulcerative colitis. About 70% of the cases associated with this. Pathogenesis is mostly unknown, but there is a combined reaction of toxin, immunological injury, and ischemia. That there is a hypothetical scheme of the pathogenesis of this PSC. Immunogenetically susceptible host is there that leads to the bacterial infection occurs. Immunologically susceptible host है, वहाँ पे infection हो गया. So this infection leads to the interleukin factors, tumor necrosis factors, activation of the epithelial cells and the endothelial cells. There will be release of interleukins 1, 6, MCPs, and secretion by the biliary epithelial cells, shedding and processing of the presentations. So antigen will be there at the biliary tract, causes the chemo attraction and activation of the neutrophils, monocyte, T and B cells, cytokine secretions, and activation of the fibroblast. This will causes the progressive obstruction and cholestasis. And this activations of TB, monocytes, neutrophils, this will causes the fibrodactylar interface hepatitis. Cytokines से hepatitis releasing cytokines will causes the destruction of the liver hepatocytes, causes the interface hepatitis, and there will be the periductal fibrosis also because of the activation of stellate cells. And because of fibrosis, blood supply will be reduced. So ischemic atrophy of the biliary epithelial cells leads to the progressive obstruction and cholestasis further, and that may cause the fibrosing, obliteration of the bile ducts, causes the biliary cirrhosis. And here also that interface hepatitis causing the obstruction of and cholestasis, and progressive portal fibrosis leads to the biliary cirrhosis. Morphologically, sclerosing cholangitis of the bile duct. Sclerosis I told you, सराउंडिंग में पूरा फाइब्रोसिस हो गया है किसके? बाइल डक्ट के. सो इट विल प्रोड्यूसेस लाइक ए ऑनियन स्किन फाइब्रोसिस surrounding the bile duct. Onion skin appearance of the fibrosis. There is a lymphocytic infiltration, bile duct atrophy, cholestasis, and the cirrhosis. जब पूरा का पूरा फाइब्रोसिस हो गया तो बाइल डक्ट की एट्रोफी तो होनी ही है, और इन्फ्लामेशन है तो lymphocytic infiltrate रहेगा. And because of this bile duct atrophy, there is a cholestasis and ultimately leads to the cirrhosis. So here you can see that this is the onion skin appearance of this fibrosis. Here you can very well appreciate it. concentric periductular fibrosis is there around the bile duct, and along with this there is a lymphocytic infiltrate surrounding this. This is the specialization mesenteric to see the fibrosis. Clinical features of the sclerosing cholangitis is it mostly occurs in 3rd to 6th decades of the life with the male predominance, while the primary biliary cirrhosis is female predominance. And in an asymptomatic stage, there is increased level of alkaline phosphatase only. With the symptomatic stage, there will be the fatigue, pruritus, and the jaundice. And symptoms of the chronic liver failure may be there with the weight loss, ascites, and the variceal bleeding, encephalopathies. And this one is the most commonly associated with the cholangiocarcinoma. What will be the treatment is liver transplantation will be required for this. So this is the comparative chart of all the 3-1 biliary cirrhosis, secondary biliary cirrhosis, primary biliary cirrhosis, and the sclerosing cholangitis. So etiology you know about this. Secondary always associated with the extrahepatic bile duct obstructions, primary possibly autoimmune, and PSC sclerosing cholangitis is associated with autoimmune with the inflammatory bowel diseases. Okay? And sex determinations, predilections is most females are most common in associated with primary biliary cirrhosis, while the male predominance is seen in the second primary sclerosing cholangitis. Signs and symptoms are mostly same in all three, that jaundice, malaise, dark urine, pruritus, loose light stools, and the hepatosplenomegaly. What will the laboratory findings? These are the common laboratory findings, that conjugated hyperbilirubinemia, increased serum alkaline phosphatase, and gamma GTT with the bile acid and the cholesterols. Along with this, in the primary biliary cirrhosis, there is a IgM autoantibodies, anti-mitochondrial antibodies are seen in the primary biliary cirrhosis, and there is a serum elevated IgM and hypergamma-globinemias are seen in PSC. What will be the pathological findings? In the secondary biliary cirrhosis, bile stasis of the bile duct, there is a bile ductular proliferations with the surrounding neutrophilic infiltrate and the portal tract edema. So what is the specific is neutrophilic infiltrate and portal tract edema and bile ductular proliferations. While in a primary biliary cirrhosis, there is a dense lymphocytic infiltrate. The characteristic feature is granulomatous destruction of the bile duct. And here, sclerosing cholangitis, there is a periductular portal tract fibrosis and onion skin-like appearance around the, or stenosis fibrosis in around the portal bile duct. Periductal portal tract fibrosis in onion skin appearance, segmental stenosis of the extrahepatic and intrahepatic bile. So this was the biliary cirrhosis. We will continue it the other causes of the cirrhosis in next lectures.